Good afternoon, everyone. Let's go ahead and begin our webinar. Welcome to the webinar today. Excuse me. Welcome to the webinar today on business planning for dementia programs, facilitated by the National Alzheimer's and Dementia Resource Center, which consists of our team at RTI International. I'm Sari Schumann with the Resource Center team, and I will be moderating our webinar this afternoon. The purpose of these webinars is to provide helpful, current, and applicable information for ADSSP and ADI grant projects and others in the Aging Network. Please note the webinar today is being recorded, and the PowerPoint presentation will be sent to all of you after the webinar. We will allow time for questions through the webinar's chat feature at the conclusion of the presentation. If you have a question during or after the presentation, please enter your questions into that chat feature. At this time, I'd like to turn things over to Erin Long from the Administration on Aging, Administration for Community Living to provide a brief welcome.
Hi, everyone. Thank you so very much for attending the webinar on business planning. I'd like to thank Deb Paone for all of her work in putting this together. Business planning for our programs and sustainability is a tremendously important component within all of our programs. With that, I won't take any more of your time. Thank you again for attending, and if you have any questions, comments, feedback that you want to provide on the webinar, my contact information will be included in the closing notes box of the webinar screen. So thanks so much, and back to you, Sari.
Thank you. As you know, today we'll hear from Deborah Paone about business planning for dementia programs. Deborah is the principal and owner of Paone and Associates, a company she founded in 2002. She has provided consultation to nonprofit, public, and investor-owned companies and organizations. Her clients include hospital and clinic systems, health insurance companies, community-based social service and housing service organizations, as well as state and local government agencies. She is also the executive director of a center that provides senior services, and she understands the importance of a business plan that matches the strategic plan of an organization when it comes to sustainability. She has also worked with the Minnesota Board on Aging on several ADSSP grants focused on serving families and people with dementia. We welcome and thank Deborah for her presentation today, and now I will turn it over to you, Deborah. Thank you.
Thanks very much, Sari. For today's webinar and the corresponding report that has been developed, I've drawn on business and management literature, particularly focusing on nonprofit business models, as well as research and technical support resources for aging and disability and behavioral health services, some practice-based guidance and expertise, and my own experience in the field. So just by way of introduction, we do know that addressing the needs of individuals with dementia and their family caregivers living in the community is a key focus of states and of aging services providers. We all recognize the growing number of individuals with dementia and the caregiver issues. So direct services providers, like many of you, are focusing on how do we bring this information, the INR, the community services, counseling, caregiver education, self-care, respite, wellness, daycare, all those good programs to individuals with Alzheimer's disease and sustain them. We know there are many evidence-based programs out there, but how do we develop and keep them going? So one key issue that plagues all of us is the lack of reliable funding. And the state units on aging, the AAAs, the ADRCs, and other nonprofits have been working to implement these evidence-based dementia services and to integrate and connect the systems of care. We know these agencies, as we all are encouraged to use business principles and practices to develop and sustain our programs. So emphasis on incorporating those principles and practices has included attention to creating the business plan, identifying and fostering a variety of funding sources, braiding those together, developing our marketing and communications expertise, and engaging in collaborative partnerships. So for this webinar and the corresponding toolkit I worked on, I'm using the framework of a business plan I'm walking through 5 chapters, as you see on your slide, one for each main section of the business plan, and these are 5 areas that are very typically contained in all business plans. And my assertion is that the discipline of actually writing a business plan for a dementia program, as for any type of program, will guide the organization and its leadership and your managers through a necessary process even before the program is launched. And it clarifies goals and objectives. It ensures that the necessary internal and external review has been done, and hopefully helps understand what are the pitfalls, what are the opportunities, and laying out financial expectations, figuring how to reach your consumers or your clients, your constituents, and defining the metrics and measures that will help ensure that your business strategy is a success. So the 5 chapters I'm going to walk through with you. First, there is the question of really what is a business model. And even though most folks think of it as the financing piece, the model is really the whole organization's approach to making and then delivering a product or service effectively. And in this case, we're talking a dementia program or set of programs. Every nonprofit has a business model, even volunteer programs, whether they are adopted consciously or not. So thinking about this and preparing for today, I looked into the management literature and experts writing for the Harvard Business Review. Business models identify the client of the consumer or consumer of product, and what does that consumer value about that product or program. So for us, parameters could be set through answering such questions as, who will be our key partners or collaborators for this program? It's very hard to go alone, 100%. So that's woven into what we want to think about. What key activities or resources are going to be required to do this? What is the value proposition of our dementia program? Not only from our perspective, from the perspective of key partners and payors. What are the dementia products or services we're offering? Who are our customers? What are the key customer relationships we need to foster? What are the distribution channels through which the customer is reached? What's our cost? What's our pricing? What are possible revenue sources? So these parameters are as important for nonprofit agencies as for-profit. And in the toolkit, I do offer some various illustrations of that. And here's just a quick example of a goal statement. This is written from the perspective of a AAA. And this fictitious AAA has decided to make an evidence-based physical activity program for people with dementia more available in their region. And so they might have an example of this kind of goal written into their business plan. Moving on from the business purpose and your goals that are the first part of your business plan, we begin talking about, well, what's going on in the environment, both externally and internally. When you're considering your dementia program, which could be a single service or a menu of programs, you will want to attend to context. So what's going on in terms of the geographic marketplace? What's the demographic profile of the area you are serving? Is that changing? Are there unique challenges in your market? Are you rural, urban, suburban? How will people who are considered the ultimate end user, the person with dementia or the caregiver, come and find and use your program? Who are possible competitors? Who are potential partners? So briefly, a business plan should describe this environment in which the program is going to be operating, and you want to think about the wide variety of dementia programs that are available. To do that and really set the foundation, you might want to conduct a SWOT analysis, which stands for strengths, weaknesses, opportunities, and threats. Usually I see the best SWOT analysis are only 1 or 2 pages. So it's a quick overview, and you are drilling down to where do we have capacity, how are we building on our organizational advantages, where do we have some weaknesses that we might want to address, what's going on in the marketplace that seems very opportunistic for us, and what are potential problems. This really helps crystallize your discussion, your leadership conversations, your planning around meeting your defined goals, and help identify some areas that need attention in order to be successful. In some cases, your threats can be turned into opportunities by partnering perhaps with another organization that offers complementary services, and you can co-market. So in considering and choosing what is our right dementia program to do for our area, there are many, many considerations, and I offer some on this slide. So first, you're going to be thinking about your target population. Are you looking at the person with the disease or the caregiver or a dyad program? You want to think about there are more than 44 evidence-based interventions we know from the work of Katie Maslow and others, and she offers a very nice set of characteristics that might be useful as you're considering what program you want to do. So things like, what's the type and stage of condition? Are you looking at early, mid, moderate, late severe stage of Alzheimer's disease? Where is the practice or program going to be delivered, or can it be delivered? You're talking about at home, in the client's home, in an office or clinic setting, a nursing home, a workplace. And then how is the practice or program going to be delivered? Is it in person, telephonic, over the computer, in a support group? So all of those things, those characteristics help you narrow what program you want to consider or set of programs. And then that will help you move into, as you narrow that, all the other input considerations or resource considerations that you want to think about. And those things are explained in the second half of this slide, which is what personnel does this program or set of programs require? Is it volunteer? Is it someone with a specific clinical or educational background? Is there additional training and skills development, information systems, clinical monitoring? What are the other resources? Do we need meeting space, travel, all of those kinds of things? Just a quick word, if you're working in a partnership, say with a healthcare entity, they may need to have extra additional activities happen for you to offer the program, say as part of their network. For example, they may ask you to sign a business associate agreement. Maybe you have different business insurance. You might need to be fidelity bonded, have legal review. So there might be other corporate costs that arise as a result of you doing this partnership for your dementia program. And then lastly, you want to be obviously looking around and seeing who are the potential competitors, I'll use that word, or service substitute types of organizations where perhaps you can collaborate rather than compete. So real quickly, this is an example of criteria for a program. You've gone through the due diligence of figuring out what your options are, and you've narrowed, and you've thought about your internal capacity and the external, and you found a program or programs that complements your program that you already have. Your organization is ready to do this. You have capacity, you have experience. It's targeting the population you're interested in where there are gaps, and there's clear potential market for it or potential payers. So you're setting forth your criteria, and those are just illustrative. So moving from the two chapters now that we've taken a quick tour through our business planning and goal setting, that was chapter 1. Chapter 2 is the program components and the operational considerations. So we've run through that. I guess I want to say one last word about that. If you are partnering with healthcare providers and health plans, they're obviously lean very heavily toward evidence-based best practices. So a strategy we're seeing throughout the field of aging and caregiver services is to build the organizational capacity around delivering evidence-based programs. And there's really good research and practice literature that tells us what factors help enhance the success of offering an evidence-based program. So we're seeing that throughout AAAs and other organizations. So now moving on to chapter 3, the funding strategies and considerations. Well, determining the financial strategy for how to create and then deliver the dementia program is obviously key to the business model and your business plan. This is what people typically think about when they talk about a business model, the finance piece, but it's really these other components as well. So we know that aging and caregiver service providers typically rely on a mix of revenue sources, federal and state service contracts, Medicaid, project grants, individual donations, corporate contributions, fees, investments, etc. And these are also relevant for your dementia program. So many nonprofits, whether they're human service providers or other providers, are faced with the same challenges, which is, the shrinking grant dollars and restricted government funding streams. And the literature does offer some opportunity for learning. The Stanford Social Innovation Review and other resources provide guidance to nonprofits as they try to develop a stronger funding model. So from this, I gathered these following recommendations as you see in your slide. Begin planning for sustainability immediately in the earliest stages of program development. Have clarity around your goals for your funding model and the programs that the organization is committed to offering. For example, your organization may not expect the program to break even, but rather act as a feeder to other revenue-producing programs. So it's really important to be clear from leadership on what the financial expectations are. When you're building your funding model, focus on possible funder motivation and their incentives, as well as the funding sources. You may need to become familiar with additional financing or funder sources that you're not familiar with, and so you'll want to seek advice from the public and private experts, third-party payers, and others so that you can braid together your funding model. Reflect on your organization's strengths and weaknesses of your current approach, and then begin to address the weaknesses and play to the strengths. And maybe your dementia program offers you a chance to stretch in terms of a new revenue source. So finally, seek information from and advice from others who have experience with your particular dementia program or a similar service. Obviously, if they're a competitor, they may not be, but there's many others outside your marketplace who probably would be willing to share information and lessons learned. So real quickly, still under the financing side, these are funding sources that many on the phone will be very familiar with. And in the toolkit, I provide some illustrations of using a sample of these funders as a source for the dementia program. So moving to some of the meat of what people find challenging, but it isn't that bad, you can do it, is the 7 steps to building a budget and service forecast. When you're evaluating the potential viability of your dementia program, you're going to need to build a budget and service forecast. And so building that, these are 7 steps that I've chosen. They're not written in stone, but I have found them useful, starting with calculating the costs, which sounds easy, but has some minutia and detail to deal with. First of all, you want to understand what the direct costs of that dementia program will be, what's fixed, what's variable, what's going into that. And so I'm going to walk through this kind of in an accelerated way, and we can talk about that. Steps 1, 2, and 3. So we're looking at our costs. You've done your homework on your program components. You understand your own salary and wage rates. I'm going to use an example, as I did in the toolkit, for a dementia program that involves a licensed social worker. She does consultation with client who is a caregiver, and it extends over multiple visits. And there's other pieces of her supporting this caregiver and the person with dementia on their learning and journey. So there are some supplies costs. There's the wage and the salary. There's some overhead. The direct costs are things like staffing, workbook materials, mileage to the client's home, and these are expenses that arise because of the dementia program, and you can't avoid them. The other costs are indirect, like overhead, rent, utilities, use of shared office equipment. A portion of these are allocated to the dementia program, but they would exist with or without the dementia program. So we also need to figure out when we're doing our budget what costs are fixed and what are variable. Fixed are those that the program will incur regardless of volume or number of units of service produced. So the purchase cost of the software that you have to use upfront, buy it, or the license for the evidence-based program is fixed. The purchase happens and it's not dependent on the number of people who are coming in the door. The variable costs are costs that vary based on volume or units. So mileage to the client's home. If no clients, no mileage. Meeting room, snack expenses, things like that. In the example I'm using, I've calculated on this right-hand side of your slide that looking at the direct, the indirect, the supplies, fixed and variable, the total equals is $53,594. And we've estimated that we can serve 48 clients under this dementia program in a year. So the 53 divided by 48 is about $1,117 per client. This is just illustrative, obviously. So as part of your building your budget and service forecast, you're trying to estimate the overall capacity. How many clients can we serve in a given year? In our example, I used a half-time social worker. I don't get to use the whole 1,080 of her hours because sometimes she's on vacation and other things are happening. So in the illustration I provide, it's about 960 hours we have to work with. And we've calculated the average time per client is maybe between 12 and 20 hours. So obviously this happens over time, and there's going to need to be a range. Not all clients are the same service intensity. So doing that, 960 divided by the 20 hours gives me a low estimate, essentially, of 48 clients that we can serve. And this, again, is just an illustration to show how you're figuring out how many people can we serve in that given year. So moving into step 4 and 5, what payer sources are available to the organization for this dementia program? So the manager is doing that good work, solid research to understand what sources in their community are available. And so for purposes of continuing my illustration, let's say they targeted payers, which include Title III Older American Act funds, that's focused on caregivers, a regional healthcare organization that's really geared up. They have a memory clinic and a program that they want to make more robust within their service network, and they're willing to build your dementia program in to their service network at a defined payment rate. Then, I know this is a stretch, but let's say there's long-term care insurance possibility from some clients where they have a copay and the long-term care insurance policy pays, and finally private pay fees. This is just, again, illustrative. So with this list of potential payers, the manager now has to determine what each payer will possibly pay for this and what is the likely volume of clients served. And you can see in this slide, again, we did some illustrative forecast with different payment rates and expected year 1 volume to equal the target of 40 clients in that first year. This is a little bit busy slide, I know, but just to keep going on this illustration, very helpful to do to kind of vary the volume and payer mix. So this shows different volumes by payer. I did not change the payer rate in this to try to keep it as simple as possible. So the manager is setting up these volume and payment scenarios and changing the mix of payer sources and volume to understand, well, what is reasonable and what is she or he going to submit to leadership as the year 1 budget. So in our example, the manager is submitting, you can see somewhere between 34 and 40, or about 34 clients, somewhere between 30 and 40 clients is the break even. At 30 clients with this mix, it slightly loses about $3,980, and at 40 it makes about $10,000. So we're saying that the manager selects these targets and submits that as the volume and budget forecast. Okay, so that was our whirlwind tour through the funding side. Now we're moving to marketing. So as you're writing your business plan, thinking about how are we going to reach the people who are going to utilize this dementia program. The MBAs talk about marketing as a function of planning, pricing, promoting, and distributing the organization's program. So like any other program or service, the dementia program needs to be developed with your business model, your focus, and your funding model in mind. We know that marketing and outreach takes time and money, and the organization needs to decide where are we going to put our resources to maximize referrals to the dementia program. And if possible, the marketing should also differentiate your program from others that are potential competitors in your marketplace. So obviously the end user, the customer, is the person with dementia and or his caregiver or her caregiver. However, there are many other potential customers, which I've called intermediaries, who will be the actual purchaser of the service and or who are key constituents in getting the service to the end user. So you want to attend to both, and I've given you examples of the type of people who might be seen as the intermediary. Given that, you might want to cast your marketing and outreach net widely, and your target audiences could include the whole general public who are potential end users or referrers, lay public, the professionals from referral sources like healthcare, clinics, hospitals, housing, senior housing. It could include elder advocacy and voluntary health organization staff like Parkinson's Society, ALS Association, Stroke Association, the state and regional helpline staff, those in helping or counseling professions, or first responders like emergency med techs, paramedics, firemen, police. So you can see, potentially this is a very big reach. So again, under marketing, in addition to who you want to reach, there's the channels in which you reach them. And you'll want to consider those pathways. How do people with dementia and our caregivers seek, find, and use your program? How, when, and why do others refer to your program? There is some information in the literature about this pathway. There's some good information about how they use programs, particularly on general caregiving and aging services. For example, some research shows that direct mail is the least effective and personal outreach is the most effective. This is giving you some of the studies. In our illustrative example that I use, we're trying to work with that healthcare provider as part of the network. That's a strategic and funding priority for our fictitious organization. And remember, based on our case example, we're trying to have at least 15 of our 40 clients in that year one come from the healthcare referrals. In fact, this particular source. Therefore, we're going to make extra effort to understand the needs and preferences of the doctors, social workers, care coordinators, et cetera. We might even tailor our outreach so that we are setting up a streamlined 24/7 secure fax and email, a direct connect electronic referral system. Maybe it's a one click of the mouse and the referral goes through. So I'm just giving you a sense of what might be involved. So in terms of the strong marketing strategy, that's a component of your business plan, and these pieces that you see on the slide are things that you want to be sure you've attended to so that you've tied your marketing strategy back to that mission and purpose for the dementia program. Obviously, it reflects an understanding of your constituents' needs. Maybe you're targeting the special populations, Latino or African American caregivers, for example, and so your marketing, your visuals, your media, everything reflects that understanding. You've done your homework in that area. You are utilizing the media that best matches with those constituent characteristics. And if it's the physicians, how do they use the media or not use the media? So that strategy is wrapping all that in. You're demonstrating an awareness of and response to other providers, so maybe you're differentiating yourself from other services out there, and you're maximizing what you bring. Perhaps a nonprofit nature, your long history of serving aging and caregivers, there may be other competitive advantages that you're pulling on. We do know it's often an adult child, family member, close friend, maybe a trusted person like a rabbi or a pastor or a counselor who is seeking out on behalf of the family information about dementia programs or even on the disease as the symptoms worsen. So building a general awareness may include stories, videos, testimonials, and that may be more compelling to that lay or counselor public than anything that's more scientific. The vignettes from caregivers speaking directly about how the program helped them may be especially compelling in your marketing approach. And we know that healthcare professionals are another important distribution channel, so you want to really understand how they are finding or seeking information and what makes a difference in terms of them deciding to make a referral. I just give this to you again that, it's kind of an easy way to remember what you need to include in your marketing, the 5 Ps, so that you're planning what is this going to do, how, why, when in the delivery of the dementia program. Your marketing is addressing that. It's really describing the products in a way, in the language that your constituents understand and value. You're ensuring your prices or your rates are acceptable. You're making sure that the places that your marketing and outreach appear really are very easy to use. The end user and the intermediary user They don't have to go out and seek it. The information is coming. It's very user-friendly. It's easily accessible. And your promotion strategy, if possible, has some sort of two-way communication so that the intermediaries and end users of your service realize the benefits of engaging with you. You're building in touch points within your promotion, if possible, and outreach that is feeding back, hopefully, valuable information and intel about how they're experiencing your program or even the referring process. And that can help really on almost a quality control or check for you. So we've done the first 4 sections, and the final section is evaluation, which I strongly recommend you have in your business plan. All good business plans have them. You need to build in a way to evaluate your results. Otherwise, you don't really know if your business strategy had any impact and whether it was successful. Again, it's not only the financing piece. So you want to put together an evaluation plan to ensure that the type of information needed that represents the values and perspectives of your key stakeholders and partners is being gathered in a systematic way. You want to gather the financial and non-financial information so it's qualitative and quantitative. You can do that through informal or formal means, and methods and sources are many. You can do telephone conversations, in-person interviews, electronic surveys. You can look at data reports, the financial data, all of that. You want to set that up, obviously, in the beginning so that you're collecting your data and you have your measures right at the get-go. And they need to be matched to the goals for your program so you can compare your results, at least in an interim, say a 6-month, so you can make mid-course corrections. And then, obviously, have the data and information you need to say, this is what our impact, this is what our results were. The potential stakeholders, you've thought about this right at the get-go, so it's not only in the evaluation, you've built it in your whole approach. But these are kind of the ones that come to mind as you're thinking about your stakeholders for the dementia program. And you may have others, and some of these may be particularly important for you in terms of both implementation and sustainability, so make sure you attend to those with some added emphasis. Okay, so as you're thinking about your evaluation plan, what specifically might be what you're going to examine? And these are just examples again. Your evaluation plan is going to have indicators and focus areas, and I've listed some, like the visibility, awareness, and marketing. How did we do? Are the different marketing communication methods working? Are we getting referrals? What's generating the most return? And it can even be down to the media that you're using, the images. You kind of want to do a touch base on that. The volume and demand. Has the service volume projections, have they played out as expected? Who or what organization is sending the most referrals to the program? Is it coming word of mouth? Is it previous clients? What's the overall demand for the dementia program? Is it growing, declining, staying constant? Then your reach. Are you targeting and reaching the specific target population groups, the geographic areas that you expected? The services delivered, how many units were you able to deliver and produce? Is capacity meeting demand? Are there patterns of service delivery emerging, like elders prefer services in the home, or caregivers want weekend and evening hours, or something like that? So look at that. Operational efficiency, are there gaps, too many steps or processes that we could eliminate? How can we streamline this? How can we reduce administrative burden? Maybe we can have others within the staff performing duties that right now our top licensed person is doing, and it can be delegated to others. The service effectiveness. How are the consumer satisfaction, customer satisfaction values coming in? Are we seeing reductions, say, in caregiver stress or burden, or whatever you set forth from the quality and impact? What about the payers and provider partners, for example? What are they seeing in terms of expectations, say, on function or on quality of life? And, of course, there's the finance piece, too. And they may have their own metrics, say, a healthcare payer/partner, that they're trying to look at the indication, how many clinic visits perhaps have, or ED visits have been avoided. So I give just a real basic here slide that talks about you could pick structure, process, output, or outcome measures, and here's just examples of the indicators around the dementia program. I think it is helpful to think about, it's helpful and more robust to have structural measures like we have this piece, we have a full complement of trained staff. A process measure, we have the referral process set forth, its structure and process, and the process is working effectively. There's no bumps in the road. Output, we have served a number of caregivers, workshops. There's X number of physicians making referrals. So that's an output as a result of our effort. And then finally, outcome. We're seeing that pre-post, the post scores are going way up. We're reducing caregiver burden. We're seeing fewer ED visits or nursing home placements. So whatever makes sense to you, I think those evaluation metrics, it's very helpful to set that up in the beginning. So I'm gone a little faster than I expected and taking a few extra breaths here. I think the message that I've tried to impart is that creating a written business plan for the dementia program is a really sound discipline. It provides a strong foundation that hopefully helps you implement and sustain your program. And as you go about researching the information needed for your purpose goals, Chapter 1, program operations and components, Chapter 2, Chapter 3, funding, Chapter 4, marketing, Chapter 5, evaluation. As you've gone through all those steps in the planning, now you have the intelligence and the information that you needed for your organization and your marketplace and your purpose and your leadership at this time and place within the climate that you work. So that this is one tool that you can use kind of as a blueprint. It gives you a clear sense of what right now you will or will not be able to achieve. And you're going forward perhaps with more confidence by having done that. That's the hope anyway. So the takeaway points that I'm offering to you seem trite, but they seemed also very tested and true. And I have called from research and practice and sound experts talking to me about what made a difference for them. And I would say this goes back to at least the early 2000s. So knowing your purpose, very important, clarifying that, clarifying your specific goals and objectives and how you want to measure those, understanding your market, what's the demand, potential payers, competitors. Got to know your input costs, the resources required, set that budget and service forecast based on very sound information. I know we all wish there were more payers and it was easier, but it isn't right now. So the tighter you can be on that, the better. Using a marketing approach and method and looking at the media, that's still a very growing area. So make sure you're matching today's marketing and communication with your constituents and how they find and access information today, and then obviously evaluating your strategy based on the metrics that you set forward. So I think in conclusion, I really want to encourage you to use the webinar and the Companion Business Toolkit report as a starting point. I did put in resource tables in the appendix of that with many additional great websites, tools, reports, other references that hopefully would be helpful along the way. And I want to thank you for the opportunity to share a bit of what I've learned and discovered along my path in serving the field as an evaluator and as a practitioner in studying and fostering programs for elders and caregivers. And I hope it's been helpful. Thank you.
Thank you so much, Deborah. That was fantastic information. I just want to remind all of the participants that I will be sending out the PowerPoint presentation that Deborah just presented either this afternoon or tomorrow for your convenience and for you to review at your leisure. And in addition, when the toolkit is available, we will send out the link for that where you can access it. So we are getting some questions in, Deborah, and I can provide those to you at this time. Just so everyone remembers, you can enter your questions here in the Q&A pod that appears in the middle of your screen. The first question that came in was asking, how do you research potential payers and what they will pay for specific services?
Okay, so I think the best starting point, and I'm assuming this questioner would have some experience in the aging services and caregiver services world. So the best
Yes.
starting point is always, you know, what you know now. So if you're familiar with, I'll assume Title IIIE, you may know Title IIIB, but perhaps not D and E. So you have, you know, partners, collaborators that you probably know very well. In the nonprofit world, we tend to share, and I love that about us. And so they're going to be a great source of information. So first start with what you know and what's worked for you in the past, and then build on that. Maybe you do all the titles to all the Title IIIEs, and so you've had experience, say, doing matter of balance or something, or, you know, explore what else is available in your state and area under those titles. And of course, your state, together with, of course, the federal government, sets the service definitions. And so if you haven't done everything, essentially, you're going to have more to learn even about that. In terms of the healthcare provider entities, which I know many are reaching out, there's some wonderful information actually through ACL, you know, the ACL Technical Resource Center and the Business Acumen, which I think this kind of falls under that as well. There's some really great case examples and other material, which I tried to reference in some of the tables, that give you a sense of how to address some of those other payors. So, I mean, obviously, it's written not specific to your marketplace, but I think a lot of that intelligence will be applicable to you. So finding out, you know, what Medicare covers, what Medicaid, different, you know, waiver programs, perhaps, if you don't have any experience with that. Going into your state may have special caregiver, I'll say, pools or block grants. You know, your state Office on Aging and Disability Service is going to be a great place to understand more about that. The healthcare, I was just starting to say, from the healthcare standpoint, you know, every market is so different, and I'm in Minnesota, and of course, you know, we've had experience with managed healthcare and healthcare consolidation going back to the early 80s. So, you know, this is going to be very different from other parts of the country, and I just say reaching out to a robust program that you know has contacts already with healthcare, or making the direct contact through to the healthcare entity along, for example, the memory, if there's a healthcare entity that's already shown interest in memory assessment and early detection and outreach. So there's really no substitute for doing the hard work of the research, I guess I'd say, which, and I'm not talking about academic research, I'm talking about your market research. There's some sort of principles of working with these different payers, and you can find some things that are useful kind of basics around those particular types of payers, like long-term care insurance. What does that typically pay for now? You can find reports and publications, but there is no substitute for knowing what's happening in your own marketplace, and really only you and your colleagues, your compadres, can figure that out. So I hope that answers the question.
Great, thank you. We also have a question. What do you think is a realistic time frame for getting a new service or program up and running?
Oh boy. Well, I mean, it depends, of course. Everything, I'm going to say that to every question, I bet. It depends on where you are already. You know, if you have, let's say, robust caregiver services, so let's say you already developed your powerful tools for caregivers. You already have an Alzheimer's support group, you know, that's facilitated in your building or in your center. You know, depending on where you're starting from, adding now a dementia-specific caregiver program may not be such a stretch for you. If you're starting from blank slate, you know, you're, I don't know, a clinic or something, and you really have never focused specifically on caregivers, it's going to be a much harder learning curve, I'll say, more steep learning curve for you. similarly, for the dementia programs, I just had earlier referenced Katie Maslow's, the 44 evidence-based interventions through that report that came out in, I believe it was 2012. That's a great source for you to just have kind of a thumbnail sketch of the different kinds of what they call non-pharmacological programs that are available. But some of them might require an OT, for example, or an advanced practice nurse. So if you don't have that, and you're not planning on hiring, or that's too much of a stretch for you, that's probably not a program you're going to select. So I think you have to look at your internal capacity as well as and do that kind of analysis about what type of program is going to fill in the gaps that you're thinking about. And I mean gaps in the services that are out there, what are the needs out there, as well as gaps in your own maybe menu of programs. So some of them could be fairly short. You get someone certified and trained in a particular evidence-based protocol, and you already have all the bells and whistles and the space and all of that. It's not going to be a big deal. I would still recommend you write at least an abbreviated business plan for that and do the cost analysis. But other things might be a much bigger deal because you're investing in a startup, essentially, in a building the infrastructure, and that it's really new to you. If you have to purchase software, for example, if you have to fly somewhere and be trained, and there's so many hours of preparation, even just in getting your staff ready, as well as your internal database. Well, obviously, that's going to take longer. And again, who's paying for this, right? So some of that funding in that startup, hopefully you have some grant dollars, some other sources, some collaborators who are willing to help get that going, because until, even with the best funding model, no client is paying you before you even have the program. So there's a lot of, that's why I think this isn't an easy thing. And that's why I do believe in this discipline of doing all that homework before you've spent too much money or time.
Great, thank you, Deb. Here's another question asking about if you have any comments related to separate payments for cognitive screening, cognitive testing, caregiver questionnaires, etc.
Okay. Well, let's see. I'm just thinking locally, and that's, I know this marketplace the best. I guess I would say that payment for testing alone, I haven't been familiar with that. Where I've seen cognitive screening, very short screens. It's been built into an approach. For example, there may be one question in a screening instrument that's built into a Title IIIE, which is caregiver. So it might be 1 out of 7 questions, for example, that deals with memory. It's not an official cognitive screen, but so that's built in. So the time that practitioner, in this case maybe a social worker, would have spent on that very brief intake with a caller or a person sitting at her desk, that's not really a cognitive screen. That's a beginning intake to understand what the needs are here. But that time would have been paid for under Title IIIE. If you're talking about other kinds of cognitive performance testing, like, there's some that OTs do that they're a provider, they can be billed through Medicare, that's a whole different ballgame. Or if it's a physician, for example, or a psychologist, or it's part of a neuro testing center, that's a whole different ballgame. That's probably a Medicare provider. But that's where I'm familiar with more, that it's built into an existing approach at intake, not a separate thing that I can bill for. But it may be in other parts of the country. Again, I'm not an expert on all 50 states.
Okay, great. Thank you. Another question. This is from someone who's giving a little bit of a situation first, and then there comes a question. As a not-for-profit, their marketing budget is virtually non-existent. So the question is there a rule of thumb to follow to help estimate the marketing budget needed to recruit someone with dementia and their caregiver, so a dyad for a new program, and assume that this is a well-established community service agency? there a
Wow,
formula for it, or?
I'm sorry, I have no idea.
Oh, you have no idea.
I wouldn't hazard a guess on that. Yes, like you, the organization I direct has no marketing budget, so I'm right there with you. But I should say that with a qualifier, and that is, yes, we do flyers, and I mean, there's obviously printing dollars built into the budget. Is it separate for the dementia program? No. So in this particular organization, which is the example I'm thinking of, like perhaps many aging services providers, senior centers and AAAs, if you're building if you want to build your visibility and the awareness in the public and in the provider world, that you are putting the stake in the ground and developing your internal capacity and your expertise around dementia, then that is an organizational strategy. You don't have to think of it only as marketing, like we don't have a marketing budget. You're spending time administratively with your, staff, practitioner staff, and others. And it's woven into now your general marketing that, this is our expertise, or this is how we reach out to people with memory impairment and their caregivers. So I don't see it as a separate budget line item. I see it as it's part of our now organizational strategy, because we believe that much in trying to fill this gap. We're seeing increasing need. And that is, I'm not saying that's the only way. I'm just saying, we're all hampered by not having fancy Madison Avenue marketing people and or dollars. And so it's the usual stretching your dollars as much as possible. So if you're going out anyway with programs, make sure you're bringing that dementia stuff along with you and doing a separate flyer, posting things on Facebook. There's some things that don't cost any extra dollars. Of course, it's staff time to develop the images and the messages. But it's not like you're mass producing or putting something on a billboard that's going to have separate costs. You're building it into your overall approach. I guess that's just sort of the practical way I think many of us have to approach this. I hope that answers the question.
Great, thank you, Deb. Let's see if any more questions come in. At this point, we've answered what's up on our board here on the questions screen. A comment came in, not a question. So in the meantime, I just want to remind everyone, because I have gotten a few more questions about it, that I will send the PowerPoint presentation either today or tomorrow once I have the participant list. So you can look for that in your email inboxes. You can also take a look at the closing notes below the question and answer pod if you need anyone's email address that has spoken today. Deborah Paone's email is there. My email is there. And then also Erin Long, if you have any feedback about the webinar, you can contact her. So Deborah, do you have any other comments that you want to add at this point?
No, I just say that I've appreciated the opportunity to provide the information, and I did provide a pretty extensive written business toolkit to RTI. I know they're working on the edits, and I'm excited to have that be out there as well. And really I hope that answers some of the questions, or that just provides more detail, because I developed this PowerPoint based on that. So they're companion pieces.
Great, that'll be wonderful. Thank you so much again for your presentation today, and we look forward to the toolkit. Thank you everyone that participated for tuning into the webinar. We look forward to having you again at a future session. So with that, we'll close out for this afternoon and hope to have all of you back for another webinar in the future. Thank you, Deb.
Thank you. Bye-bye.